Bismillahirrahmanirrahim. Welcome to ERA. I am Dr. Muhammad Talat, Assistant Professor of Radiology Beni University. Today we will discuss one of our most important cases because it's relatively common, and our case or our teaching lecture today will be full of many teaching points. I hope to be an interesting lecture, inshallah. I would like first to thank Dr. Elborgy, Assistant Lecturer of Radiology, Beni Suef University Hospital. She shared with me this interesting case. I would like to thank her first. Let's start our case. An adult patient presenting with disturbed conscious level. I think it's obvious to pick up the abnormalities. We have acute subarachnoid hemorrhage along the sylvian fissures, more on the left side, so it's asymmetrical. Even the subarachnoid hemorrhage extends along the extra-axial CSF spaces on the left frontal and the parietal regions. Inferiorly, the subarachnoid hemorrhage extends along the basal cisterns of the brain, and to a less extent extends along the interhemispheric fissure. Once we have subarachnoid hemorrhage, we should grade the severity of the subarachnoid hemorrhage. Please watch case number 6 in our course, how to grade the subarachnoid hemorrhage by modified Fisher scale. I will not repeat the same data again. Once we have subarachnoid hemorrhage also, we should search for any complications. The most common complications is hydrocephalus. Really, we have mild ventricular dilatation. Look for the third ventricle, mildly dilated. Both lateral ventricles are also dilated. Even the temporal horns are mildly dilated, more on the right side. Temporal horns dilatation is very important to pick up early hydrocephalic changes. Also, we have one of most common complications of subarachnoid hemorrhage is cerebral infarctions. Cerebral infarctions can occur in association with the subarachnoid hemorrhage because subarachnoid hemorrhage can cause vasospasm of the arteries in response to the subarachnoid hemorrhage, and this vasospasm can make or can cause cerebral infarctions. So we have two main complications. Hydrocephalus, we have hydrocephalus, but we don't have any acute cerebral infarctions or any gross cerebral infarctions. Let's think together what are the causes for the subarachnoid hemorrhage. We mentioned before in one of our last videos that we have traumatic and non-traumatic causes for the subarachnoid hemorrhage. The traumatic causes, regarding the traumatic causes, subarachnoid hemorrhage is mainly involving the peripheral part of the brain. But once we have central part affection or basal cistern affection, we should think for non-traumatic causes of subarachnoid hemorrhage. And the most common causes for the non-traumatic subarachnoid hemorrhage, first is cerebral aneurysms. Second is AVM. Those are the most common causes for the non-traumatic subarachnoid hemorrhage. We have less common causes. For example, cerebral amyloid angiopathy is considered one of the causes for non-traumatic subarachnoid hemorrhage. We will focus today in cerebral aneurysm. So if we start to pick up the abnormalities again, we will find the subarachnoid hemorrhage is more extensive on the left side as compared to the right side. So if I want to ask you, what is the side that you can predict the cerebral aneurysm, you will tell me for sure the left side, mainly along the left sylvian fissure. Let us review the anatomy of cerebral wells and the common sites of the cerebral aneurysms. We have here the internal carotid artery, and the internal carotid artery divides into middle cerebral artery and anterior cerebral arteries, and the basilar artery here divides into left posterior cerebral artery and right posterior cerebral arteries. So we have also, this is a communicating both the anterior cerebral arteries on both sides, and we have also BCOM that communicates the internal cerebral artery or the terminal end of the internal cerebral artery with the posterior cerebral arteries. If we have the subarachnoid hemorrhage is more condensed along the interhemispheric fissure, we will think of the ecom aneurysm, this side. So this one, ecom aneurysm. If we have the subarachnoid hemorrhage is more condensed along the Sylvian fissures, we will think for aneurysm in the bifurcation or trifurcation of the middle cerebral artery. If we have the subarachnoid hemorrhage at the base of the sternus, we will think for three sides: isis aneurysm at the tip of the internal carotid artery, or BCOM here. For this is the most common site for BCOM at the junction between the posterior communicating artery and the internal carotid artery. Also, the basilar tip can be one of the commonest sites. So again, if we have the subarachnoid hemorrhage is localized or condensed along the interhemispheric fissure, we will think for ecom aneurysm. If the subarachnoid hemorrhage is localized along the Sylvian fissures, we will think for the bifurcational aneurysm at the middle cerebral artery. If we have the subarachnoid hemorrhage is localized at the base of sternus anterior to the bones and the midbrain, we will think for three sites: BCOM, basilar tip artery aneurysm, and also internal carotid artery tip aneurysm. If we have the subarachnoid hemorrhage is localized as the extra-axial CSF spaces of the posterior fossa and sometimes extends inside the fourth ventricle to be intraventricular hemorrhage inside the fourth ventricle, we should search for pica or ICA aneurysms. Those are very rare, but we should know these arteries very well. Sometimes the subarachnoid hemorrhage is localized at this site and the CT angiogram is negative, and this one we can call it non-aneurysmal perimesencephalic subarachnoid hemorrhage. We will discuss this one in details in next video, inshallah. I want to emphasize one important tips. Sometimes the subarachnoid hemorrhage along the interhemispheric fissure or arising from the ecom aneurysm can extend intraparenchymal into the frontal lobe, and in case that we have subarachnoid hemorrhage along the middle cerebral artery along the Sylvian fissure, if it is very extensive, it can extend into the temporal lobes. So in some cases it's not common, but in some cases subarachnoid hemorrhage can extend to make parenchymal or intracerebral hematomas, as we discussed. I'd like to add some important principles. CT brain in the acute phase within 2 or 3 days is more sensitive to detect the subarachnoid hemorrhage. Once the subarachnoid hemorrhage exceeds 3 days, CT brain will be less sensitive, and the flare image, MRI flare image, once we exceed 3 days, the CT brain will be less sensitive, and MRI flare image will be more sensitive. If the cross-section imaging is not sensitive and we should exclude possibility of subarachnoid hemorrhage, sometimes we need to do lumbar puncture surgery or zazofrom. Those are some principles how to report a case of subarachnoid hemorrhage. So CT angiography is recommended, and we will see together what is the results of the CT angiography. Before going to the CT angiography, I have some basic informations that I think all of you should know. We have 2 types of aneurysms. If this is the artery and this is the artery, or this artery divides into 2 main branches, and there is aneurysm at the site of bifurcation or trifurcation. This is end wall aneurysm, and this is the most common end wall aneurysm at the site of the bifurcation. Sometimes we call it bifurcational aneurysm. The less common type, this is the artery, and we have side wall aneurysm. This one is called side wall aneurysm. This one is less common, and this one is more common. So if we need to search for any aneurysms, start by searching for any bifurcations for the arteries. This will help you to pick up the aneurysms easily. We did CT angiography for this case, and inshallah we will discuss this one in more details in next video. And by the end, I would like to thank you all for listening our teaching sessions. Thank you so much.